Good afternoon, good morning, and welcome to Foundation Frontiers, a new medical education series hosted by Foundation Medicine. I'm Jen Mills, the Vice President of Medical Affairs, and I'm thrilled to be joined by an incredible cast of panelists here today, Mark Szynski and Holly Dilks, whom I'll introduce in a moment. But first, in the spirit of full transparency and disclosure, our disclosures. This session is presented by Foundation Medicine, and Mark Szynski is a consultant receiving financial compensation. You see the additional disclosures listed here. On the next slide, please. Also flagging that both Holly and myself are employees of Foundation Medicine, and you see Mark's respective disclosures here. And with that, allow me to introduce today's session, beginning with our incredible speaker, Dr. Mark Szynski. Mark is the Executive Medical Director of the Advent Health Cancer Institute. He's a medical oncologist by training, specializing in thoracic malignancies. He's also an internationally recognized expert in the development of novel chemotherapy agents and treatment strategies for lung cancer. Mark has served in countless leadership positions within cooperative groups and research consortia alike, including serving as the co-chair of the Thoracic Malignancy Steering Committee for the National Cancer Institute. Next up is my colleague, Holly Dilks. Holly currently serves as the Senior Medical Director and Global Head of Medical Field at Foundation Medicine. She joined FMI in 2019 to build alliances with the scientific and medical community. And prior to that, she spent 15 years or more on the front lines of building precision medicine programs, including serving as the Director of Personalized Medicine Operations for Sarah Cannon Research Institute. While she's an expert in many areas, she has a special passion for community oncology and education. And with that, Mark, I'll turn it over to you to provide some perspective on where the state of lung cancer is today, introduce liquid biopsy, and walk us through a few case studies.
Great. Thank you, Jennifer, and welcome, everybody. You can see the topics for today. We'll have a little intro to liquid biopsy and a case study, and then some innovations in terms of how we use liquid biopsy for comprehensive genomic profiling, and hopefully plenty of time for discussion and Q&A. So next slide. Next slide here. Yes, so here is the number of approvals we've seen over the past decade or so with regard to targeted therapies and immunotherapy. And we really have much better understood the underlying biology of cancer and been able to create novel targets with novel therapeutics. Many of them fall under the category of targeted therapy. We also know the power of the immune system and how immunotherapy has really changed the landscape for many solid tumors. You can see it allows us to be much more precise in our therapeutic recommendations. And just taking my disease of interest, which is thoracic malignancy, non-small cell, you see there has a long list and hopefully growing list of agents with activity based upon understanding the genomic landscape of the underlying tumor. Next slide, please. Specifically in lung cancer, we know that there are 9 or 10 clinically relevant targets with regard to either fusions or mutations in which there are, in most cases, multiple FDA-approved agents for these subsets. EGFR really led the pack. We are now celebrating the 20-year anniversary of the first description of EGFR mutations. Other BRAF, HER2 mutations, the fusions like ROS1, RET, ALK, in NTRK that we can see in non-small cell lung cancer. And it's important to establish the genomic landscape of the tumor at the time of initial diagnosis, certainly in stage 4 disease. And we now have indications for targeted therapies in the adjuvant setting with regard to EGFR. If there is not a so-called oncogenic driver, then the immunotherapy markers listed to the right, principally PD-L1, are important in helping us make treatment decisions with regard to therapeutic recommendations for our patients. Next slide. Even though, as I've said, it is the absolute standard of care that every lung cancer patient with non-small cell lung cancer have a comprehensive genomic profiling of their cancer. That should be 100% for all the known markers with FDA-approved therapies. We know that that's not the case. There are a number of barriers listed here, so-called administrative barriers with regard to just getting the order in, how the EMR works, locating the results in an efficient fashion, unfamiliarity with the rapidly expanding number of indications and drugs that we use in this particular setting, concerned about financial burden to either the patient or the system. None of us practicing oncology are molecular pathologists, so the reports can be quite complex, quite long in certain cases, with lots of findings, some of which is relatively unclear, perhaps in certain instances somewhat confusing to the non-molecular pathologist. We know lung cancer also can be a tough disease anatomically. To get adequate tissue for comprehensive genomic testing. We know liquid testing has become part of the standard of care. Having said that, we also are concerned about turnaround time. It's slightly less for liquid biopsy than tissue-based testing, as noted. And sometimes it's difficult to wait or be patient with the waiting for the results to try to make a treatment decision. So next slide, please. And I've mentioned the issue of insufficient tissue in poor DNA quality. Obviously, sometimes the biopsies can be scant in nature. There's a limited amount of tissue, or it gets used up by doing excessive immunohistochemical stains. Old biopsies that can be unreliable because of fixation techniques that may compromise the DNA. And then we've largely steered away from bone biopsy. I remember when I was in my training as a fellow at the Dana-Farber, bone biopsies were fairly commonly done to establish a diagnosis. Of course, that was a time when all we really wanted to know was it small cell or was it not small cell? Certainly times have changed here. We know that the decalcification procedures with bone can compromise DNA quality. Next slide. Now, what is circulating tumor DNA? So we know that this is tumor that's DNA that's derived from cell death. It can be shed into the systemic circulation. In terms of advanced cancer cases, more than 75% have detectable ctDNA. This is an amalgamation of alterations found at all the tumor sites gaining access to the blood. It represents a small fraction of the cell-free DNA. And certainly there are certain factors that may impact the amount that's shed by tumors: tumor burden, tumor type, and perhaps timing and type of most recent therapy. But this is there for the taking, if you will, to identify these oncogenic drivers. Next slide. Now we have some language from the NCCN clinical practice guidelines shown here. These are recommendations for plasma ctDNA, the so-called liquid biopsy. This should not be used in lieu of a histologic diagnosis. Obviously, that's paramount in establishing a diagnosis of cancer as well as histologic subtype, as it makes a difference with regard to chemotherapy selection. And this is really routinely recommended only in advanced stage disease. We still don't know the role for early stage disease. This is a tissue-based setting. And we know that when you have a lesser volume, say perhaps metastatic disease confined to the chest, that the yield actually may be higher with tissue-based testing. It has been demonstrated in several studies, the high specificity between ctDNA and tissue testing. And it's important to remember that both ctDNA and tissue do have appreciable false negative rates, supporting the really complementary nature of these two approaches. And that's how I view them in my practice, is that really this is not one gold standard, but two gold standards, in my opinion, if you will. They're complementary. Next slide. Again, I've mentioned the specificity between the ctDNA and tissue testing. Again, the false negative rates we've talked about. The limitations of ctDNA are important to understand: the low tumor fraction or low amounts of circulating tumor DNA. This can affect the sensitivity. The presence of mutations from sites other than the target lesions. Most of these have to do with clonal hematopoiesis or post-chemo marrow clones. And again, the inherent ability of the assays to detect fusions or other genomic variations that may have relevance in the management of the patient. Next slide. So we have a case study here. 68-year-old gentleman with advanced non-small cell lung cancer presents to the oncology clinic after a bronchoscopy, which in my opinion sometimes or often doesn't get adequate amounts of tissue. We have a histologic diagnosis, adenocarcinoma of the lung. We don't have, well, oh, no, I'm sorry, we have evidence of stage 4 disease with a PET scan showing a large lung mass, as well as liver and adrenal mets. The patient is symptomatic. What do you do at this time? If we could advance the slide, a liquid biopsy is sent because there's uncertainty about the tissue adequacy from the bronchoscopy. And obviously, you want to make a treatment decision as soon as possible. 8 days later, the liquid biopsy reports no actionable alterations. So the question is, how reliable is this negative liquid biopsy? If we can go to the next slide. You can see here that when you have negative liquid biopsy samples or driver negative liquid biopsy samples, that tissue comprehensive genomic testing can identify additional drivers. To the left here, we see comprehensive genomic testing via tissue after a negative liquid biopsy. And you can see 37% of the patients after that negative liquid biopsy do have findings in the tissue, and the alterations that you see are pretty much representative of what we would expect in this particular setting. So this really drives home the complementary nature of this. We've mentioned before that you can't trust a negative result because you don't know if it's because of lack of ctDNA shedding by the tumor. So in this setting where you have a negative liquid biopsy, it's important to do comprehensive genomic testing. And the question is, can we move past this and really get more information from a negative liquid biopsy that would help us in making treatment decisions? And I think if we go to the next slide, Jen, I am going to turn it over to Holly.
And actually, Mark, thank you so much for that fantastic overview and perspective on where the field is and where the field of liquid biopsy is heading. Maybe before we head into Holly's section, I'll just ask you a few questions, and I would encourage our audience to put any questions that you have in the Q&A feature. We really want this to be interactive. We're here for you and would love to hear from you. So Mark, maybe I'll just start. You've given us a great overview, and it sounds like there could perhaps be no more exciting time to be in lung cancer than today. Tell us a little bit more about what excites you. What do you think about when you think about innovation and treatment and diagnostics when you're seeing your patients?
Well, I think liquid biopsy or so-called ctDNA testing has really revolutionized the practice of thoracic oncology. We have historically dealt with scant tissue specimens. I remember, if you go back 8, 9 years ago, it wasn't unusual to do a second biopsy to get tissue. This was in the early days of liquid biopsies, if you will. I think we've established the role. I think what excites me in this arena, there are lots of things that excite me in lung cancer in general, Jennifer, but in this arena, it's how do we, I think we've established the clinical utility of liquid biopsy at the time of initial diagnosis of advanced stage disease. That's incontrovertible in my opinion. The question is, how do we use it to monitor response? How do we use it to switch from to next line of therapy? How do we use it in the earlier stages of disease? Our colleagues in colon cancer are using informed circulating tumor DNA to make clinical decisions about adjuvant therapy and stuff like this. And I think that's where this is heading. I think we will establish that it will have a role. I'd like to see the clinical investigations that really define what the clinical utility is in that setting.
And when you talk to your patients today, how do you describe liquid biopsy to them and just the quest for understanding their biomarker-driven disease as a whole?
I tell them my job is to get them the right treatment at the right time. And the most impactful thing we do is the thing we do first. So you better get it right because the patients don't always have a second shot on goal, so to speak. So I tell them that I consider cancer a disease of your DNA. We must interrogate the DNA to see if it gives up any secrets. We do that in the tissue. And actually, your tumor may be shedding some of its DNA into your blood. And that's another way to do it. It's a simple drawing of the blood. We do it right in clinic, and we move on. And the turnaround time, as I've mentioned earlier, is usually roughly about a week, plus or minus a day or so. So that's very helpful for patients because I can schedule them back in a week or so and have an answer where the tissue may take some longer time point. So patients understand, and obviously, again, we want to get the right treatment to the right patient at the right time, and it requires in lung cancer the genomic understanding.
Fantastic. Well, I see a lot of questions in the chat, and actually, I might hold on some of them. I believe Holly will touch on a few of them, including the small cell lung cancer question and a few others. So, Holly, maybe if you can dive us a little bit deeper into the innovation hosted by Foundation Medicine.
Sure. Thank you so much, Jen and Dr. Szynski. I'd really like to now share some recent data about how Foundation Medicine has been innovating in the CGP liquid biopsy space to really enable providers to distinguish when those further follow-ups could be merited for a driver negative liquid report. So when we hone in on whether driver negative results are truly negative, Foundation scientists have really been working to uncover this and have developed an algorithm called ctDNA tumor fraction. Simply put, ctDNA tumor fraction is a determination of the amount of circulating tumor DNA as a fraction of the total cell-free DNA in a blood sample. Moving forward in this session, for simplicity's sake, I will be referring to ctDNA tumor fraction just as tumor fraction. If we look across various solid tumor types, you can see that the amount of ctDNA shedding calculated via tumor fraction varies. In our experience, around half of all non-small cell lung cancer tumors that have been sequenced via Foundation's liquid assay have tumor fraction greater than or equal to 1%. Other tumor types, such as colorectal and breast cancers, have a larger percentage of samples containing greater than 1% tumor fraction. If we go to the next slide, traditionally liquid-based NGS tests relied on variant allele frequency, or VAF measurements, to estimate the sensitivity of the test. However, after much research, we now know that VAF measurements are not a reliable estimate of test sensitivity, as sometimes they can overinflate or even underinflate the amount of ctDNA present. We've found that mean and median VAF are not correlated with tumor fraction. In fact, mean and median VAF can be influenced by non-somatic variants. The violin plot on the left side of this slide shows that there's a large amount of variation in the VAFs detected, and that the detection of variants near 50% frequency, these would be suspected to be germline, can skew those mean VAF calculations. Clonal hematopoiesis variants that are clustered at VAF under 10% can also overestimate ctDNA content in blood. Because of this, the tumor fraction algorithm relies on calculating levels of aneuploidy for higher level estimates of ctDNA, and at lower level estimates, tumor fraction considers the variant allele frequencies of certain alterations that are likely to be tumor derived, while also we use fragmentomics to potentially filter out the noise that might be coming from clonal hematopoiesis derived variants. And on this slide, detecting rearrangements and fusions is critical for clinical decision-making in cancer care, as these genomic events represent an actionable class of genomic drivers. Historically, though, detecting genomic rearrangements by ctDNA-based NGS techniques has been a very difficult task. Several reports have found inferior detection of genomic rearrangements in liquid biopsy compared with tissue biopsy assays. And some of these historical limitations of liquid biopsy have included finding lower rates of detection of fusions, low concordance in matched samples with tissue partners, and even a reduced diversity of fusion gene partners. The clinical cancer research study that we're referencing here from 2023 examined the landscape of liquid-based results from Foundation's tests compared to results from our tissue test. And in this study, the sensitivity of the liquid test to detect driver rearrangements was much higher in samples with tumor fraction greater than or equal to 1% than those with tumor fraction less than 1%. The study also demonstrated detection of a wide variety of rearrangements in liquid biopsy, comparable prevalence of driver rearrangements in tissue and liquid biopsy when that tumor fraction was greater than or equal to 1%, and a distribution of fusion gene partners that resembles the distribution of fusion partners seen in tissue biopsies. So if we go to the next slide, we've now established that tumor fraction is the key factor in liquid biopsy concordance for tissue biopsy detected alterations. So to reiterate these data that Dr. Cieszynski was talking about from the ASCO 2023 study, when tumor fraction is less than 1%, there's an opportunity to detect additional driver alterations. And so reflexing to a tissue-based assay should be considered for complete therapeutic decision-making. However, when the tumor fraction is greater than or equal to 1%, there is a low frequency of missed alterations. If we go to the next slide, since high tumor fraction really does build confidence in driver negative results, we want to make sure that we're clearly reporting this value. So recently we've changed our clinical reporting categories to high, low, and then cannot be determined. High is reported for situations where tumor fraction is greater than or equal to 1%, and the actual percent is provided on the report. Low is reported for situations where tumor fraction is less than 1% and the percent value is not given. Cannot be determined is reported for a rare situation where QC metrics have not been met. Next slide. Hopefully now you're seeing that ctDNA tumor fraction really does build confidence in driver negative reports. If we think back to the 68-year-old man with advanced non-small cell lung cancer and the driver negative liquid report that Dr. Cieszynski discussed, we can now dig in and determine whether the driver negative report is an informative negative or an indeterminate negative. If there's a high tumor fraction, then we would say that this report is an informative negative, and we have increased confidence in treatment for driver negative disease. However, since the report did have low tumor fraction, we would say that this report is an indeterminate negative, and we would prioritize confirmatory tissue testing to potentially detect additional alterations. Now, I do want to emphasize one point here. Whenever the report is driver positive, no matter what the tumor fraction is, we recommend pursuing the appropriate targeted therapy option for this patient. So instead of having a tissue or liquid first NGS testing philosophy, we really believe it's important to focus on the patient when determining which assay is the most appropriate or which one to go first with. If a quality tissue specimen is available or the patient has disease that is unlikely to heavily shed, we would recommend a tissue first approach. However, if a quality tissue specimen is not readily and immediately available, we would recommend starting with a liquid-based test. And we believe that taking all of these factors into account really does enable that patient-first decision-making framework to equip providers, as Dr. Cieszynski was talking about, with the information they need to make the most appropriate therapeutic decision possible for their patients. Thank you. I'll turn it back over to Jen.
Fantastic. Thank you, Holly, for that deep dive. And maybe we'll actually start with your last point. There are a good number of questions in the chat, and some of them center around how to really trust a negative or trust a positive. And you mentioned the high shedding rates having an impact on how we might think about liquid biopsy. Maybe, Ryan, if you don't mind pulling up the slides and going back to the waterfall plot, we have a question specifically about small cell lung cancer, recognizing that we're generally talking about non-small cell lung cancer here, but wanted to invite some conversation, Holly, from you from a perspective on the shedding of small cell lung cancer. And Mark, clinically, if you can share a little bit of perspective about how you think about liquid biopsy or genomic testing as a whole in small cell.
So are we talking about small cell or non-small cell? Sorry.
Small cell specifically.
Oh, small cell. If you look at the plot that we had with that slide, you'll see that small cell actually has a very high level of shedding. That tumor type is actually one that a very large percentage of patients do have more than greater than or equal to 1% tumor fraction. It's actually on the far left-hand slide, part of that slide that we were showing. And so actually, it is actually quite a good candidate for a liquid-based test. But Dr. Cieszynski, I'd love to hear your thoughts from your experience as well.
Well, it may be a good candidate to find something in the blood. The question is, what are you going to find that's going to make a difference to the patient? And we don't really have any targetable alterations in small cell at this point. Now, I will remind the listeners that every once in a while, and I've had this happen in my practice a couple of times, we have had a few cases of small cell that show up with an EGFR mutation, and we do know that there's a low rate of transformation, and so the thinking there was that they had clinically occult EGFR mutation positive disease that transformed into small cell. And so but that's pretty rare in practice. So again, in small cell, most of the alterations are in tumor suppressor genes. We really don't have a good therapeutic plan for tumor suppressor genes. There are no, fusions or mutations specifically in which targeted therapies have a role.
Thanks for that perspective. And Holly, maybe the last point that you made about trusting a positive, trusting a negative, can you dive a little bit deeper there for us?
Sure. So, for sure, we found that even in situations where tumor fraction is less than 1%, there are still situations where there's a strong driver that is positive. And there are plenty of publications showing that those drivers are targetable and actionable, and that patients respond when they are put on the targeted therapy for that driver. So, definitely, if there is a driver on the report, even if the tumor fraction is low, that's a great thing. And we know you can move forward confidently. I think with tumor fraction here now, the study by Dr. Rolfo and colleagues really has highlighted that when tumor fraction is greater than or equal to 1%, and that's where we show that on the report, that we feel quite confident that the driver alterations that were tested you will see them, and there's very little chance of finding other alterations at that case. And also the fusion work that was done by Dr. Sabaya and others with us also showed that fusions are detected at greater than tumor fraction greater than or equal to 1%. So that's also showing the confidence that you have if the tumor fraction is higher and the report has no detectable alterations, that you've looked and not found anything, and you can be confident with that.
Fantastic. Thank you. And I think you both have really nicely highlighted how complex the field is and how quickly the information is evolving. Mark, maybe you can comment a little bit on the top 2 or 3 things you think clinicians today need to think about when treating patients with lung cancer.
Well, I think the most important thing is to get the diagnosis right. I mean, we still don't see, and I believe that comprehensive genomic testing, in my practice, I do both tissue and blood in almost all cases, but there are a few exceptions, obviously. Comprehensive genomic testing is part of the diagnosis. It's like ER, PR, and HER2 in breast cancer. No oncologist would make treatment decisions without knowing those biomarkers, and we should look at lung cancer in the same manner. You have to know all 9, 10, 11, however many there are at the time of diagnosis to make the right choice. And we know in this country that testing rates are not where they need to be. So that is really the take-home message, because you will miss the chance to make a huge difference in the life of a patient by not getting the diagnosis right. So it starts with a proper diagnosis. I would also add, you got to know exactly the stage to figure out what to do, but the stage and diagnosis are really the take-home messages, and you cannot cut corners on establishing them.
Fantastic. Well, I know we're at the top of the hour. I want to thank both of you, Dr. Cieszynski and Holly. Thank you so much for your contributions and perspective. And thank you to all of our participants. We look forward to seeing you on the next Foundation Frontiers. Have a great day.
Thank you.
Bye.